So we're just going to take a moment to further discuss assessment. Also some things that people in the past, in the early 1980s, identified about assessment by taking a qualitative approach. So essentially there was a researcher who brought in 5 osteopathic physicians, had them all assess multiple patients for pain in the same region. And what was noted, and I'll link to the research so that you are able to identify it, able to read it. Essentially what was identified was 5 classifications of tests. 2 of them were considered unique to osteopathy or osteopathic practice. Those 2 were deep and superficial palpation and a local response to motion demand. The one that was spoken about as far as motion was concerned, that was inclusive in many medical professions, was gross motion tests. Now, we'll talk about that a little bit more in a moment, but one of the things that I want to do is identify and show through example how a lot of these things, although written differently on paper, blend into the same thing. So the gross motion testing, or the gross motion that is shared between multiple medical professions or multiple healthcare professions, essentially would be something like sit up as tall as you can, stick your tummy forwards, right? So looking at global vertebral extension. Now, if I was to take that, right, and talk about the concept of local response to motion demand, if I just look at any area in the patient through the vertebral column and I ask the question as somebody who would be observing, essentially what's happening in this local region, if I create the large motion, the small motion is occurring anyways and I'm able to assess it. So when I speak about my concept of macro identifies micro, so large movements identify small problems, where a motion is made up of multiple components, the subcomponent problem shows itself. That is spoken about in this research piece. The gentleman's name was Dinnar, D-I-N-N-A-R, and again I will link to that so that it's available for you to look at. The other thing that was consistently noted is that the same practitioner would do multiple tests for the same thing with different patients. So they wouldn't always use the same test, they would use different tests. So one of the things that seems to be an observable characteristic of osteopathic practice, or the actual hands-on practice, is that people will use multiple tests to test the same thing. But the thing that unites it all is motion. So I just want to touch briefly on the concept of deep and superficial palpation. So if we were looking at the region of the trapezius, it may look as something as simple like this: superficial palpation, deep palpation. What I would say as an observer of that, and also as a practitioner, is that I consider soft tissue palpation, especially when you push through to deeper layers, I would consider that a motion test. I would still consider that local response to motion demand, because I'm creating an external motion and I'm seeing how that tissue responds to the motion. Now we're going to, again, kind of just switch a little bit of the conversation here to go back to try to sew these concepts together. So we have the reality that I can do a patient active test. I can have the patient, as we already saw, essentially go into full vertebral extension. Another thing that I can do, just shimmy back on the table a little bit. Okay, give yourself a hug. Right? I can do something like this, right? So I can use the patient's arms as essentially as handles, so that I can lift, right? So I can use my body, and you may not see this, but if I lean forward, I can essentially create flexion for him. If I kind of hip check, and lean backwards, I can create some extension. I can use my palpatory hand, and I can at least claim that I'm creating some form of lumbar extension. So that's another example of local response to motion demand, right? So a patient passive, full body lift by the practitioner to check lumbar extension. I would suggest to you that's not necessarily an effective way, but I want to show you alternative ways to test the same thing. If we have you on your back, right? So again, we're still talking about lumbar extension, and we're trying to identify the fact that the same practitioner can approach the same thing in multiple different ways, right? So we're going to have you bend your knees, right, together. Now, immediately upon hip flexion, you suspect that there should be lumbar flexion rather. Please excuse me for the mistake. But if I go ahead and I lift both knees up, then I can start to, right, compare. So I know that I'm creating flexion, and as I come away, anything that doesn't essentially stays flexed, it doesn't begin to flatten out or approach extension, I can claim that as a flex segment. So that's another way to test for lumbar extension. The other thing that's available to me there is, as I create the flexion, any segments or any region, any portion that doesn't actually create the flexion, doesn't go into flexion as expected, that could be considered an extended segment. Okay, we're going to have you on your stomach for a moment. Okay. We can talk about a short lever, so again, local response to motion demand. Right, so I just push in, and if something doesn't go forwards, then I can consider that a flex segment because it hasn't responded as I would expect to the demand of motion that I'm placing on it. Right? I can have the patient just come up on your elbows. Right? And any segment as I palpate through here that doesn't go into extension, I can again speak about the fact that it's likely flexed because it has not extended as I would expect. Now all of these are testing the exact same thing. So in multiple positions, and you can just lay down and rest. In multiple positions, I can test the same thing in different ways, essentially, or at least the surface level is different ways. The reality is that I'm just creating lumbar extension, whether I'm having the patient actively do it, whether I'm providing the motion passively, so the patient is passive. In all of these contexts, I'm creating lumbar extension and seeing if it happens. So with the research that I will link to, what it speaks about is the fact that, again, these practitioners all take different approaches. They all use gross motion testing, and then within that gross motion testing, they likely separate it out. They do the gross motion testing maybe to identify where they might want to look more, and then they'll do some form of motion in the region that they're interested in to further localize what they would call the somatic dysfunction or the motion dysfunction. That being said, it is also noted that what will often happen is to create the local motion, they will use a gross motion. They'll use a large motion, which again ties back to the concept that I put forth that macro identifies micro. So the large motions identify the smaller problems. So I would say that the qualitative approach taken by this research project is something that I wasn't necessarily aware of when I began to synthesize through observation my own essentially heuristics, or the heuristics that I've put forth that other people may have, but I've spoken them. Now that being said, I didn't know about that piece of research. I found it more recently, so what it can do, and I want to be careful with this, and I would like to suggest that all people be careful with this, is it can provide an opportunity for confirmation bias. It allows me to further believe what I already believe. I don't know that that's a safe thing, but at least in the short term, it seems to lend some credence to what I'm talking about, that when you observe a broad range of osteopathic practitioners, they all use motion testing. Motion is really the only thing they actually observably test, and when they test it, they'll use a larger motion to identify a smaller problem. Now they may use the gross motion test and separate it out from their local motion tests. That's neither here nor there, but what ends up happening is they all have observably multiple approaches to test the same thing in different people. So the hallmark may actually be that multiplicity of approach, because when you understand that what you're trying to create is one specific motion, be it hip extension, lumbar extension, shoulder flexion, vertebral side bending, it doesn't matter. You can create that in any position to the best of your capacity, understanding strengths and weaknesses of each position and each approach. But because each patient presents a little bit differently, you have to have different positions to place the patient in, different approaches, patient active, patient passive, long lever, short lever. You need to have those available to you, because sometimes the methodology will not be appropriate for the patient, and it may not be appropriate for the practitioner to perform on that patient. Some patients may be very small, very young. Some patients may be considerably larger than the practitioner, so you have a patient and practitioner mismatch in that case. So the hallmark actually seems to be that osteopathic practitioners will create the same motion, the same goal motion in many different ways, and it's been classified, at least in this research project that I'm talking about, as a local response to motion demand. So we want to understand that this isn't a phenomenon that is isolated, that hasn't been seen by anybody before. It's been seen, at least on paper, as early as 1980, or essentially described appropriately on paper as early as 1980. So we want to leave that with you and just help you understand that when the test that you're trying to create, or when the thing you're trying to test, you can't test it in the way that you've been taught. Well, what you need to start to think about is, how do I create the goal motion? Now, I would suggest that having an overarching assessment protocol in an organized fashion, as I've spoken about in the past, having an order of operations when you don't necessarily know what's going on. But sometimes when the patient comes in and they've been hurt and you can tell which motion is the problem, then you can devise your own test at that point. However, I would suggest a good algorithm, a good overarching assessment protocol when you're not sure what's going on, and then the ability to be dynamic and change it when necessary, because not every patient presents the same and you can't perform the same test on every patient. So again, we want that organization, we want that ability to orderly approach the patient, effectively approach the patient, with the understanding that sometimes my approach is not the appropriate one and I should be dynamic enough to change it. So these are the things that come together to form assessment. So you have your kind of stock assessment, and then when that's not working, you need to understand how to create the motion in other ways.